All right. Hello, everyone. Thanks for the opportunity to be here and talk to you about approaches to management of microscopic colitis. These are my disclosures. This is the outline of my talk. I'm going to briefly talk about epidemiology and pathophysiology of microscopic colitis, focus largely on some of the emerging concepts in the field. I'm going to spend most of the rest of the time talking about diagnosis and treatment of microscopic colitis. So just a little bit about epidemiology of microscopic colitis. As most of you know, microscopic colitis is an inflammatory disease of the large intestine. The disease was actually first reported not that long ago, first in the late 1970s in the setting of individuals who were presenting with chronic diarrhea of unclear etiology. Today, we know that it can account for up to 20 to 40% cases of chronic diarrhea, depending on age and demographics. And certainly the incidence has dramatically increased over the past 2 decades, although for the most part, it has plateaued over the past 5 years, largely due to increased recognition of microscopic colitis, as well as increased utilization of colonoscopy as part of the workup for chronic diarrhea. The incidence today rivals that of other classical inflammatory bowel disease, such as Crohn's and ulcerative colitis, and it ranges based on different studies, anywhere between 3 to 10 cases per 100,000 person years. As most of you know, women are much more likely to be affected by microscopic colitis, up to 3 or 4 times more likely to get diagnosed with microscopic colitis. And as we all know, the disease primarily affects older adults with peak age of diagnosis somewhere in the 60s and 80s. So just to highlight, what I just said, this is a recent review that was published in Nature by our group, looking at some of the sort of data on incidence of microscopic colitis over the past few decades. And as mentioned before, certainly the incidence has increased largely due to increased recognition, an aging sort of population, as well as increased utilization of colonoscopy. And then this graph shows the incidence of disease according to age and also is stratified by men and women. And as you can see, women are much more likely to be diagnosed with microscopic colitis, and really the peak age of diagnosis tends to be in sometime in the late 70s to early 80s. So what about some of the risk factors for microscopic colitis? Well, traditionally, the disease has thought to be related to medication. And so a lot of people sometimes actually refer to as a medication-induced colitis, with a number of medications that have been previously implicated. And then also a number of epidemiologic studies have shown other potential risk factors, such as smoking, and then GI infections, particularly C. diff, and viral infections such as norovirus, and then more recently, COVID infections. Interestingly, some of this sort of previously established thoughts about microscopic colitis, that this is largely a medication-induced colitis, has recently been challenged. These are 2 studies that were published now about 3 years ago across 3 different centers in the US. And in these 2 studies, what the authors did, they looked at the prevalence of use of implicated medications among individuals who were presenting with chronic diarrhea and presenting for colonoscopy for the purpose of assessment of the cause of chronic diarrhea. And what was interesting in both of these studies was that majority of the previously implicated medications were not only not associated with increased risk of microscopic colitis, but in some cases, they were actually less likely to be used by individuals who ultimately were diagnosed with microscopic colitis. So the study on the left actually did not see any association, with the exception of NSAIDs, and risk of microscopic colitis. And the study on the right actually did not see any direct associations between any previously implicated medication and risk of microscopic colitis, really challenging this widely established hypothesis that microscopic colitis is a medication-induced colitis. Now, I would say that these are small case control studies. There are single-center, multi-center studies. And so I would sort of be hesitant to say that these studies are practice changing, but certainly brought up this idea that maybe this disease is actually has nothing to do with use of medications. And recently, we have also explored this hypothesis. We did a large nationwide study in Sweden where we looked at over nearly 3 million residents in Sweden over the age of 60, and look to see if initiating these previously implicated medications are associated with increased future diagnosis of microscopic colitis. And our results were interesting. So, consistent with prior studies, we showed that pretty much every single medication that we looked at was associated with higher, subsequent risk of getting diagnosed with microscopic colitis. But then when we looked at the same relationship with getting a colonoscopy, what is the chance of these individuals who are starting these medications? What's the chance of them getting a colonoscopy? With normal biopsies, we saw almost identical association. So not only these medications were associated with increased risk of microscopic colitis, but it appeared that actually taking these medications is associated with higher risk of receiving a colonoscopy and getting biopsies, really highlighting that these prior studies may have sort of shown these associations largely because prescription of these medications is either associated with higher healthcare utilization, or prescription of these medications are done in the setting of individuals who already have symptoms consistent with microscopic colitis, such as, for example, PPIs, such as, for example, SSRIs, or even in some cases, NSAIDs. And so our conclusion of this study was that, sure, we observed an increased risk of microscopic colitis with initiation of previously implicated medication, but most of these associations were equally observed with receiving just a colonoscopy with completely normal biopsies. And so these previously reported associations were likely related to surveillance bias and diagnosis bias, and likely do not sort of demonstrate a causal relationship between taking these medications and subsequently being diagnosed with microscopic colitis. And really, the conclusion of the study was this idea that we should be very careful about balancing the intended benefit of these medications against the likely, non-existent or non-causal relationship between these medications and risk of microscopic colitis when you think about potentially withdrawing these medications in individuals with established disease. So beyond this sort of idea that medications may not actually be associated with risk of microscopic colitis, and we should really think carefully about withdrawing medications in individuals with microscopic colitis, there've also been emerging data on the role of genetics and microbiome in microscopic colitis, and we've seen a slew of sort of publications from a genetic standpoint where a number of large-scale genetic association studies have been done. The majority of these genetic association studies have shown a strong relationship between both HLA and some of the non-HLA variants and risk of microscopic colitis, demonstrating this sort of polygenic nature of the disease. And what's interesting about these genetic association studies is they have also shown sort of shared genetic between microscopic colitis and our classical inflammatory bowel diseases such as Crohn's and ulcerative colitis. So they've sort of provided some insight into potential shared mechanisms between microscopic colitis and other classical inflammatory bowel disease. There've also been a number of smaller scale microbiome studies where they've attempted to understand sort of changes that occur in the gut microbiome in individuals who are diagnosed with microscopic colitis and comparing it to either individuals who don't have diarrhea or individuals who have diarrhea without microscopic colitis. And certainly there's clearly a shift in the composition and function of microbiome in patients with microscopic colitis. Interestingly enough, a lot of these changes are similar to what we see in other classical inflammatory bowel disease such as Crohn's and ulcerative colitis. So there's really emerging data on the role of genetics as well as the role of microbiome in development of microscopic colitis. together with epidemiologic studies that show maybe medications that have been widely implicated as potential risk factors for microscopic colitis may not be associated with microscopic colitis. And so, our conceptual framework and for understanding the cause of microscopic colitis has certainly evolved. We now know that medications may not be the primary risk factors for the disease, but other factors such as older age, smoking, sex, GI infections, and some of the other ones that I didn't have time to go over it appear to be strongly linked to microscopic colitis. And so our overall sort of hypothesis is that that microscopic colitis occur in individuals who have some genetic susceptibility to developing microscopic colitis and who have had some changes in their gut microbiome as a result of some environmental factors such as GI infections, such as smoking, such as aging by itself, that may ultimately lead to this inappropriate immune response to these changes in the gut microbiome. All right, so with that sort of brief introduction about epi and pathophysiology of microscopic colitis, let's sort of transition and talk more about diagnosis and treatment of microscopic colitis. So as most of you know, the gold standard for diagnosing microscopic colitis are taking random biopsies. There have been a number of studies that have looked at the yield of biopsies and where to take these biopsies. For the most part, what we know is if we take 4 biopsies from the right and left colon, we have really the highest yield of making the diagnosis of microscopic colitis. And so in practice, typically I just take 2 bites from the right colon, particularly either the ascending colon or proximal transverse, and then 2 bites from the descending colon. And this excludes rectum. And there have been a number of studies that have looked at, what happens if you just do a flex sig, take biopsies from the rectum and sigmoid. And unfortunately, we know that the yield dramatically reduces, and you could potentially miss up to 20 to 30% of cases when you do not take biopsies from the proximal and right colon. This is particularly true for cases of collagenous colitis, where this collagen deposition can be very patchy, and it typically affects the right and proximal transverse colon more than the left and the descending colon. So certainly, making sure that at least every attempt is made to take biopsies, some biopsies from the right colon, to significantly increase the yield of diagnosis of microscopic colitis. What about endoscopically? What do we see? Well, the most common finding is normal mucosa, but in some individuals, you may see mild erythema, edema, nodularity, petechiae, scalloping, almost appearance of a celiac disease. In some individuals, you could actually see ulcerations and lineal ulcers, and that's rare. And then sort of the classic case report of classic cat scratch like riff with insufflation, which is primarily what you see when you get to the right colon, when you look at the ascending colon or cecum, and I'll have some pictures of that to show. So this is an example of an individual in my practice was ultimately diagnosed with collagenous colitis, and what you can see is largely normal mucosa, but then up in closer look, you kind of see the scalloping and granularity of the colon mucosa. And this is an example of a cat scratch appearance with insufflation, which was observed in the ascending colon, where you can kind of see these linear erosions as you go through the colonoscopy. So the diagnosis, as I mentioned, the gold standard is histologic findings. And on histology, you typically see this expansion of intraepithelial lymphocytes, or IELs. In the case of lymphocytic colitis, the standard diagnosis is to have more than 20 IELs per 100 epithelial cells or per high-power view or focus. And typically in a normal mucosa, you see less than 5 IELs per 100 epithelial cells. Additional things that you may see is this expansion of lamina propria with lymphocytes, plasma cells, eosinophils, and then rarely neutrophils. And really what separates this condition to other classical inflammatory bowel disease is minimal to no architectural distortion, so no really evidence of chronicity. So crypts appear normal. There's very little, if any, cryptitis or crypt abscess in patients with microscopic colitis. In the same case of collagenous colitis, really the primary diagnosis is based on the expansion of the collagen band, which tends to be greater than 10 micron. In somebody with normal mucosa, the collagen band is typically less than 5 micron. And then similar to lymphocytic colitis, you can also see this epithelial lymphocytosis, so expansion in IELs, as well as expansion of the lamina propria with immune cells, which primarily include lymphocytes, plasma cells, and then rarely eosinophils and neutrophils. And again, no evidence of crypt damage or architectural distortion in patients with collagenous colitis. Every now and then you may actually get this read from your pathologist that says that there are some features that are consistent with microscopic colitis, but the histology doesn't fully meet the criteria. So this typically happens when individuals have greater than, let's say, 5 IELs per 100 epithelial cells, but they don't meet the greater than 20 in lymphocytes per 100 epithelial cells. And so these are cases that we call incomplete microscopic colitis. And by the way, that's also true with collagenous colitis, where you can see an expansion in the collagen band. It's typically greater than 5 micron, but not really at that 10 micron that is required to make a diagnosis of collagenous colitis. And most of these patients, we believe that they respond well to the standard treatment for microscopic colitis. So either these are evidence of early evolving microscopic colitis, or you may see this in individuals who have had partially treated microscopic colitis. So for example, somebody who's on budesonide, still having some symptoms, you go and do a colonoscopy and you may see this, some features of microscopic colitis, but the histology doesn't fully meet the criteria. And so this is sort of typically what you see in somebody who's partially treated for microscopic colitis, or again, somebody who has sort of their diagnosis evolving, and ultimately they are potentially going to get diagnosed with microscopic colitis, and you kind of catch this in the early stage of disease. So what about laboratory findings or other things that we can use to either make a diagnosis or monitor disease? Fecal calprotectin is probably by far the most widely studied laboratory in patients with microscopic colitis. And I would say that for the most part, you don't see the elevations that you typically see in classical IBD in patients with microscopic colitis, and that's really what limits the utility and utilization of this biomarker in monitoring microscopic colitis. However, in some patients, you may have significant elevation in fecal calprotectin. And so likely monitoring calprotectin, both from a standpoint of diagnosis and monitoring response, is limited in patients with microscopic colitis, but something that you could consider on a case-to-case basis. Other stool markers have been tested. Some of these are listed here. For the most part, none of these have been shown to be good markers, both for diagnosis or for monitoring of patients with microscopic colitis. So they don't really have a clear role in managing patients with microscopic colitis. So now that we talked about diagnosis, let's move to the treatment of microscopic colitis. And I'll talk a little bit more about clinical guidelines, specifically AGA guidelines for management of both lymphocytic and microscopic and collagenous colitis. But before doing that, I want to talk about some of the pivotal clinical trials that have been published in microscopic colitis, and there are only a handful of them. So this was a study that was published in 2014 in Gastroenterology. It was the first randomized controlled trial of budesonide in patients with collagenous colitis. And this was a trial where they randomized individuals to budesonide versus mesalamine versus placebo for 8 weeks. The budesonide dosing was 9 milligram daily. The mesalamine dosage was 3 gram daily. And the primary endpoint in the study was clinical remission, as defined by having less than 3 bowel movements a day, and as well as less than 3 bowel movements a day without any watery diarrhea, so no bowel movement that met the criteria for having loose or watery diarrhea. And as you can see here, the results were impressive for budesonide. So over 80% of the individuals on budesonide therapy met both sort of endpoints, both the clinical remission A endpoint as well as clinical remission B endpoint, meaning that they had less than 3 bowel movements a day, and all their bowel movements were formed at the end of 8 weeks. And this was compared to 44% in mesalamine and 59% in placebo for the primary point, for the first primary endpoint, and then for the secondary primary endpoint, it was actually lower for those two groups at 32% and 37.8%. So certainly significant differences between budesonide and placebo, as well as budesonide and mesalamine. And there was really no difference between mesalamine and placebo, meaning that this was one of the studies that demonstrated that there's probably limited role in using mesalamine in patients with collagenous colitis. A similar study was done a few years later for lymphocytic colitis. Again, similar design, where individuals were randomized to budesonide versus mesalamine versus placebo. The only difference between this study was because there could be day-to-day variations in individuals' bowel movements. What this study did was they defined clinical remission as having less than 21 bowel movements in the last week of treatment, and less than 6 watery bowel movements in the last week of their treatment. And again, similar to the other study that we showed, there was a significant number of individuals that responded to budesonide. So in this study, anywhere between 80 to 90%, depending on how you define their endpoint. And this was significantly different when you compare it to both mesalamine as well as placebo. Interestingly enough, there was some response here that was observed with mesalamine, even though that the response was not statistically significantly different from placebo. So again, these were the two pivotal studies that showed that budesonide is really a very effective treatment for patients with both collagenous colitis as well as lymphocytic colitis. One of the challenges, though, in treatment of microscopic colitis is how do you maintain individuals, meaning that 80-90% of folks respond to treatment, but unfortunately, a large proportion of patients have relapsed of their symptoms when they come off of the treatment. And these two natural history studies that were published both in Europe really highlighted this. The top study in France followed 130 patients, showed that unfortunately up to about 50% of individuals, at least in this study, were either steroid dependent or had complete relapse of their symptoms when they stopped treatment. And then a similar study, a multi-center study in Europe, similarly a larger study, followed individuals for a year and showed the same thing, that really sustained remission was only achieved in about 30-40% of individuals. So in this study, specifically in 40%, with risk of individuals either having not requiring budesonide therapy or having this chronic active or relapsing disease course, so up to 50% similarly in this study. So that really highlighted the need for studying some sort of a maintenance therapy for individuals with microscopic colitis, and really was premise behind this randomized trial that was published subsequent to the initial randomized trial of budesonide in collagenous colitis, where they took a subset of individuals who had responded extremely well to budesonide and randomized them to a maintenance therapy on a low-dose budesonide versus placebo versus really no treatment. And the results were impressive. So in the group that did not receive budesonide maintenance therapy, close to about 80% of those individuals had relapse of their symptoms, meaning that they had recurrence of diarrhea at 1 year, while over 60% of individuals who were maintained on budesonide therapy were in remission at 1 year. In this study, the way they dose budesonide maintenance therapy was anywhere between 3 to 6 milligram, and in subset of individuals, actually, they receive alternating dose of 3 and 6 milligram daily. So again, another study highlighting that actually a significantly larger proportion of individuals unfortunately have relapse of their symptoms after coming off of budesonide therapy, and we could potentially use a low-dose budesonide therapy to maintain remission in a sort of a significant proportion of individuals. So these are AGA guidelines. I would highlight that these AGA guidelines are quite old. They're from 2016, and hopefully there'll be new guidelines for management of microscopic colitis soon. But really want to highlight a couple of things. The primary treatment, first-line treatment for symptomatic microscopic colitis, and I really highlight symptomatic because there are individuals who have really more benign course where you diagnose them with microscopic colitis. Histology shows microscopic colitis, but then by the time they come in and see you in clinic, they say all their diarrhea have resolved, or they have minimal to no diarrhea at all. And so in that subset of individuals, an over-the-counter anti-diarrhea medication such as loperamide or Pepto-Bismol may be appropriate. But individuals who are symptomatic, really the first-line treatment should be budesonide at 9 milligrams for 8 weeks. Many folks do a tapering after that initial 6 to 8 weeks, going down by 1 tablet every 2 weeks. In individuals who cannot afford budesonide therapy, you could also consider second-line therapies, and that is primarily bismuth or prednisone. So again, the treatment is for 8 weeks. In individuals who have relapse of their symptoms, you could consider a maintenance dose of budesonide anywhere between 3 to 6 milligrams for up to 6 to 12 months. I will say that in some folks in my practice, I've had them on a lower dose of budesonide, like 3 milligrams, for longer than 6 to 12 months. And there's now good safety data suggesting that most people tolerate lower dose of budesonide, could tolerate low dose of budesonide for a long period of time. And then in individuals who do not have a response to budesonide therapy, really looking for alternative explanations of diarrhea, and if those alternatives are not identified, then looking for escalation of treatment. And I'll talk about a little bit about some of the options there. So really, the single immunosuppressive drug that have been most widely studied in the setting of patients with microscopic colitis who don't respond to budesonide or need a higher prednisone dosing to control their symptoms is anti-TNF therapy. And both European and Spanish consensus statement do recommend use of anti-TNF therapy as first line in individuals who don't respond to budesonide therapy. There have been a number of single-center and multi-center studies looking at vedolizumab as an option. This is a very attractive option because of its safety profile and sort of patient population that you're treating. And so it's an option that I use quite a bit in my practice as well. And there have been a number of case series looking at some of the other options, including budesonide MMX. So this is a chronic formulated version of budesonide, looking at ustekinumab, and then more recent data looking at some of the JAK inhibitors, particularly UPA, in very refractory individuals with some success. And then really rarely we would consider surgery or diverting ileostomy in patients who don't respond to any of these treatments. What about dietary changes? A lot of folks ask about gluten-free diet. The bottom line is in non-celiac patients, gluten-free diet has really no role in treatment of microscopic colitis. In patients with celiac disease, sometimes, maintaining a gluten-free diet can actually help treat their microscopic colitis. So that's something to consider and discuss with patients who have both celiac disease and microscopic colitis. And this was a study from the Nurses' Health Study cohort where we looked at consumption of gluten and risk of microscopic colitis. And really, as you can see here, there was no associations between how much gluten you consume and subsequent risk of microscopic colitis among non-celiac patients, highlighting that gluten likely has very little role in terms of controlling symptoms in patients with microscopic colitis. This question comes up a lot in terms of need for surveillance. Most observational studies have shown no increased risk for both colorectal polyps or cancer. There have been slight marginal increase in risk of lymphoma. We think a lot of this is confounded by higher rates of smoking in this patient population. And again, slightly higher mortality rate in patients with microscopic colitis, which we think this is largely attributed to increased burden of comorbidity in this patient population. And then lastly, a question that comes up every now and then in practice in terms of higher rates of inflammatory bowel disease in patients with microscopic colitis. This was a study that we published about 3-4 years ago in Gastro, showing that there is an increased risk of Crohn's and UC in patients with microscopic colitis, but if you actually look at the absolute risk increase, it's really marginal, about 2 to 3% absolute increase in risk of developing Crohn's and ulcerative colitis in patients with microscopic colitis. So certainly something to consider, especially if there are changes in symptoms over time, but really something that rarely happens in clinical practice. So in conclusion, microscopic colitis is a chronic inflammatory disease of the large intestine that primarily affects older adults, particularly older women. A diagnosis is made through histologic evaluation of biopsies from both right and left colon. First-line treatment is budesonide, which is highly effective. And there's really limited role for discontinuation of medication in disease management, since we don't fully know whether many of these medications are actually causally linked to microscopic colitis. There is a role for use of low-dose budesonide in individuals who have relapse of their symptoms. And we think that low-dose budesonide is, for the most part, safe in majority of individuals. And then in individuals who don't really respond to budesonide or have or cannot be maintained on higher dose of budesonide, on low or higher dose of budesonide, we would consider anti-TNF, anti-integrin, and then rarely oral JAK inhibitors in those patients.